Hi, everybody. A few familiar faces in the room. I'm Fiona, and I'm the nurse specialist in the clinic that we run in Tala, that's for children with Down syndrome. So I'm just going to talk to you a little bit about, I suppose, the history and how the clinic was actually established. What we know about health screening for children with Down syndrome, you probably know a lot of that information yourselves, but I suppose it's telling you what we've learned from being part of the clinic and what we've learned from parents and children that come in, that we know kind of things that are a bit more prevalent. So we see about 430 families that come to the clinic, and they range from the ages of from birth really up until the age of 16, when they should be then discharged to adult services. So there's two clinicians in the clinic and myself, Professor Malloy, who you've already met, looks after the babies up until the age of 2, and then Dr. Balfe then takes over the children's healthcare needs then over the age of 2 up till 16. So I'm just going to kind of tell you about, I suppose, what I mentioned, what we've already learned, and why these things are important to us, I suppose, and what we're going to do with the information that we have learned. And a lot of the questions that you might have had in your heads with Rob's presentation, hopefully we'll be able to kind of give you a little bit more kind of guidance of what we've actually done. So we set up the clinic in 2015 in Tala. And prior to that, we kind of done an audit, prior to its establishment, done an audit of 58 patients by Dr. Niamh Lagan, who's now a consultant in Temple Street and St. Michael's House. So she audited the charts of 58 patients. And what she did was follow the guidelines from the medical interest group of the certain areas that we should be looking for. So things like, are the children getting their eyes checked? Are they having their hearing assessed? And whether they're having their bloods and whether they're having that schedule, if it's being met or not. So what we found from doing that audit, that many children from that number of 58 were not actually receiving the appropriate screening that was happening, that was advised. Also, what was happening from a practical level as well is I was obviously based in the hospital and going down to outpatients, and I might see Rob on a Monday with his child going to an endocrine clinic to get their thyroid checked, and then I might meet him again with his son on Wednesday for a hearing check. So it actually kind of seemed a bit silly to me that parents are having to take time off work, children are having to miss school. And again, we kind of don't want to over medicalize things for children as well. So that's, I suppose, where the idea of the clinic kind of came about from. So we look after children within the areas of Dublin, Wicklow, Kildare, and we kind of ideally don't want these children to be attached to any paediatricians in the community. So, for example, children that might be living over the north side will be attending Dr. Lagan. So there's no need for us to be kind of doubling up with the appointments either. So it's mainly for our families that wouldn't have a paediatrician in the community. So basically, we set up the clinic and we tried to make it as multidisciplinary team approach as we possibly could. So what we were doing was kind of doing all the medical checks within the one day. And we thankfully had a lovely audiologist who's just unfortunately retired last week, who was also screening the children's hearing when they were coming in for clinic. So it was really beneficial that we'd have a really nice approach to kind of the care that we were given. So in 2018, we then kind of looked again at the charts and, seeing if any differences had been made from setting up the clinic. So we did notice that there was a significant increase in the adherence, and also parent satisfaction was also really good feedback from parents as well. So and we then kind of thought about, I suppose, what service improvements were needed. So things like obstructive sleep apnea and celiac disease, which I'll talk to you a little bit about more so in the next few slides. So this is the paper that was produced as a result of the audit. You'll be getting a copy of all these slides, so some nice bedtime reading for you all over the weekend. But you can have a look at them anyways if you have interest in the area. So what do we know? What did we already know? So we knew obviously that there were medical guidelines, and I'm sure many of you many moons ago are probably handed that big bulky document in the maternity hospital, which is something that we don't really want to happen because it obviously tells a lot of problems to parents that may not actually even be applicable to their child and their health. But all these guidelines were created on the basis of international research, and as Dr. Balfe mentioned earlier on, there is health guidelines as well available on the Down Syndrome Ireland website, and the UK groups as well also have links. So it's a difficult one, I suppose, when we are discharging children from the clinic at the age of 16, that we don't have a kind of a mirrored clinic in the adult services. Obviously, a lot of adult clinicians are very kind of condition focused. So say, for example, an endocrinologist will just look after things like that. So it's very difficult to actually have the pediatric and pediatrician approach where they do this kind of holistic approach to care. So it is difficult, and it's kind of got to the stage now where when you're so long in a job, it's a sign of the times, but you're kind of saying goodbye to families that you would have met when they're in their early childhood. So it's difficult for us as well as the parents kind of leaving us. So what do we do? In the clinic, we do a brief clinical history, and we do a developmental review. We also do the annual bloods, and they're listed there. We also have kind of really good links in Tala. We all kind of, the teams work quite closely together. So things like obstructive sleep apnea, we kind of troubleshoot these things before they become really problematic. And as I mentioned, we do a lot of things in around health promotion of different vaccines, etc., which have all the evidence from, or the information that we give has all come from the studies that have taken place in the DISCO group. So from doing the clinics, I suppose we kind of found certain things that were, that we needed to check for. So we have a lot of different doctors that come in every 6 months, and they change over, and they be coming to our clinics, and they may never have actually provided care to a child with Down syndrome, and certainly didn't know what to actually look out for in detail. So we did come up with these clinical performers. So we have one up until the age of 1, so they'd be for the infant clinic, and then we have an older age group as well. So basically the essence of the clinical performers is that anybody who comes into the clinic has exactly the same questions asked by whatever clinician they might see on that given time. So we'll ask the same questions, and anybody who comes to the clinic nearly knows the script at this stage and can probably preempt what we're going to ask. But again, a lot of our care is kind of screening and surveillance rather than, it being problematic. So it's just kind of a tick box exercise, as you can see here, but it makes things, I suppose, easier for us to kind of keep track. So what do we find, I suppose, from doing the clinics over the years? We obviously noticed that there is differences in immunity and the children's abilities to be able to fight infection. We also noticed the sleep disturbances, which is well documented in the research, and the increased incidence of sleep apnea. Celiac disease is obviously more prevalent as well. Again, immuno-driven responses. Vitamin D, dermatology, again, I'm going to go through these one by one. I won't focus on too much now, but dermatology as well. We see a lot of children coming in with a lot of skin conditions that, again, trace back to the immune response to infection. So I'm just going to go through them one by one. So I'm not going to focus too much because I know Rob has obviously covered a lot of this, but the study that Rob was speaking about earlier on by Dr. Huggard, he carried out a screening basically of 114 children that attended our clinic, and each child had a blood sample done. And they were compared to children without Down syndrome, and the differences in their immunity levels was mapped basically. And we found that children with Down syndrome had increased immunodysregulation, which Rob has already talked about. But this in turn, I suppose, led to us to kind of tailor our care a little bit differently and be a little bit more open, I suppose, to treating infections quicker in order for children not to have, obviously it's going to have an impact on their development if they're getting current infections. And again, it has an effect on the whole family unit. So we kind of came up with a lot of different vaccine recommendations, and thankfully the HSE has recently brought out the vaccination programme in relation to RSV. So that's the really nasty virus that usually children get before the age of 1. But we know that children with Down syndrome have been getting this virus and been really knocked for 6 with it. A lot of our children would have ended up in ICU and would have been really ill during the time of when this virus was was active. So we're really grateful, I suppose, that the HSE has brought this vaccination campaign out, and it's something that we've been working. I know Prof. Malloy has been working in the background a lot to try to get children with Down syndrome to receive this. So it's really going to be a game changer, especially for the next few winters. Also, then we do a lot of health promotion in relation to the flu vaccine. It's so simple now for children to get that. It's just a nasal spray, and I suppose the benefits of that. And if you worked in the clinical area that we do, you see children coming in really sick again with the flu. So it's something that's preventable and manageable if we promote it. Also then, so things that mightn't be weird and wonderful viruses. So we have a lot of children that be coming in and they'll be just getting infection after infection after infection. And sometimes it becomes normal to the families that they're just firefighting all the time and they're back and forth to the GP. But what we usually do is if we take a good history from families and we find that they're having kind of 3 or 4 infections in the winter and they're finding it difficult to fight those infections, we would recommend prophylaxis antibiotic. So what it is a low dosage antibiotic that we give 3 days a week. And we usually kind of run that from the months of September till March, those kind of acute months for infection. And it works, anybody whose children are on it, it works brilliantly. So I think our role again is to promote that to families and make people aware that there is treatment out there for those recurrent infections. In relation to the sleep apnea side of things, we did a study on it and we kind of found that about 50% of the children in the clinic were presenting with signs of sleep apnea and positive studies. So with that, we have aligned ourselves with the American guidelines that we screen all the children that come into clinic before the age of 6 for sleep apnea. And this lovely photo Ross features, he's not here now, but he features, we applied through the Hospital Saturday Fund in Down Syndrome Ireland to fund dedicated sleep apnea monitors for children. So we are going to be now distributing them in the clinic to about 2 families every clinic. So again, we'll be able to kind of, I suppose, accelerate any diagnoses that might be outstanding for families. We also, obviously, when we're doing that, giving out these machines, we're going to be able to document how many we've given out, how many children have been positive, and what further treatment have they needed, if any. Also then sometimes, the sleep disturbance and the apnea isn't sleep apnea or medically related. And sometimes again, it's families coming in and us actually taking a good history from families. So, it can be things like sleep hygiene, like families or parents sitting beside their kids when they're going to sleep at night time. And then when they wake out of the REM, usually around 3 o'clock in the morning, they look for that parent, and that's just basic sleep hygiene that can be worked on. So we give a lot of information on behavioural programs that might help as well with that practical side of things. Also, we mentioned the use of melatonin, so that's kind of our last line treatment that we would use. If all the other avenues are kind of exhausted, we would go through the melatonin route. So we've also produced a paper in relation to celiac disease again, and these are all listed at the end, so you can have a look at them if you like. We've reviewed celiac screen results from 2007 to 2017 of 212 children, and we found 7.5% of children will have celiac disease. So I suppose why is this important? We know that long-term exposure to gluten, if you are celiac, can have kind of detrimental, obviously it causes a lot of discomfort, but it also has an impact on growth and bone health as well. So we really obviously want to make sure that we identify this quickly. So we screen children annually as a result of this. This is one I always have a problem pronouncing, but it's keratoconus. So we were approached by Dr. Power in the Royal Victoria, so the Eye and Ear Hospital. And what he was finding was it was young adults were coming in to his clinic with Down syndrome. And when he looked and examined them for this condition, a lot of the young adults may have been asymptomatic, but were presenting with signs of it. So he asked us to give this information to the families that come to the clinic, and any children between the ages of 12 to 18 were offered screening. And this is an ongoing project, and there's a paper just actually due to be published on it in the next few weeks. But the early results have just indicated that about 15% of the children that we actually sent have got the condition. And it's really treatable and manageable with eye drops if it's picked up early. But if it's not, some of these young adults will need corneal transplants going forward. So keep an eye out for that paper. It's on the way. So practical stuff from obviously from living in Ireland with our lack of sunshine. We know that vitamin D is really problematic in anybody that lives in places that don't have great sunshine. But we did a study on 184 children, and we found that 10% of children had deficient levels. But actually, more interesting was 48 had insufficient levels. So they all needed basically the 48% of children need to be treated. And we do recommend, the HSE also recommends that we take all year round supplements in relation to vitamin D. So this has excuse the pun, a knock-on effect on our bones going forward. If we don't treat it, you'll get kind of aches and pains in your joints. And also that will have an effect then on mobility going forward. So we continue to kind of check the vitamin D levels, and we provide information to families as well. CHI also have a lovely handout here as well. So as I mentioned, insufficiency and deficiency, the differences and how we treat that. So that's available as well. So some of the more practical stuff that might relate to some of the families here, we regularly see people, children coming in with dermatology issues, and some are problematic, and some others are not as problematic. But again, we reckon that this is all driven by the altered immunity levels. So things like fungal nail infections that can be really difficult to treat, and there's topical and oral things, but it's something that we've kind of seen a lot from the children coming in. This Keratonis pilaris as well. It's all kind of Harry Potter language, but otherwise known as chicken skin. So that's a nice one. And a lot of Irish people have it. It's kind of these lumps on your skin. And again, you know, we obviously treatment is moisturising and Milton baths. Hidradenitis suppurativa is a little bit more troublesome, and we see this in a lot of teenagers where they come in and they've got really excoriated, you can see here in the picture, really excoriated kind of boils. A lot of the times in girls and young men, they'll kind of present in the groin or on their buttocks. And again, these can be really uncomfortable and difficult to treat. So again, we kind of treat them with oral antibiotics and refer to dermatology. And even we have a lot of teenagers that come into the clinic, and a lot of the families wouldn't be obviously monitoring their children when they're showering and that. But it's just good to kind of keep this and bear this in your mind at the back of your mind to ask your teenager, do they have any problems with their skin, or are they worried about anything? Because it can be quite uncomfortable. So I'm just going to finish up about kind of transitioning and services. We know that the young adults that have a history of congenital heart disease are followed up in the Mater Hospital, and the children that might be still affiliated with cardiology in Crumlin will be transferred to them. Unfortunately, as I said, we don't mirror the service that we offer in adult services. So a lot of the times we will write to the GP advising what checks these children will need, and young adults, I should say, will need going forward. But as Dr. Balfe and Rob spoke about, I suppose staying fit and healthy is the most important thing for all of us. Strength training and conditioning is really good for your mental health and as well as your physical health. And social interaction is so important as well, and engagement for your emotional health. And also keeping an eye on weight management, which can be problematic in young teenage years. So we also have an interest as well in the way that parents are informed of the diagnosis. It's something that I did my thesis on, and it's something that we would like to kind of look into further. We also, as a team, provide education sessions to medical students and midwifery students in relation to how they should deliver the news and how they should communicate with families that have a child with Down syndrome. And I suppose that's so important to us to kind of build the foundations to try to improve some of the experiences that we've heard from families. And we do listen, you know, to all those bad stories that we've heard over the years, and it's something that we would like to kind of work on a little bit more going forward. So this is just a paper that was produced from that study. So what's next for us? We hope to continue with providing the clinical service, obviously, that we provide, and also to produce more research within the area. So we've got a really good large number of children that come to the clinic. As I mentioned, there's about 430. And I'd say if you ask 99% of those families, they are really happy to engage in research. I'm really happy to provide the evidence that we need, I suppose, to improve the health of children of the future. So we're really, I suppose, I just want to thank Joe at the end, who couldn't be here tonight, who's a member of staff here in Trinity, but also helped advise in relation to the presentation. And the advice she gave me, I asked her as a parent, what do you want us to do? And it was all about engagement and listening to parents. And I think that's just so important, to make time in our busy schedule and your busy schedule to do that. These are some of the papers. And thank you to the families, most importantly, the families who we meet. We can all read as many textbooks and research papers as we want, but at the end of the day, what we learn is from families and the kids that come to the clinic. So thanks very much.